Okay, a couple things about this. This is the best description that I've seen. Clearly, among psychiatric disorders, bipolar and ADHD are the ones that have the strongest evidence of genetic transmission. Okay, but strongly influenced by environmental factors. And this is really important because we're going to see that there are no home run pills when it comes to bipolar disorder. You've got to do lifestyle management and a bunch of other stuff too. So there are other things other than just medication. This is not what I was taught in graduate school, and I don't think most people were. I was taught, as people have for decades, that you have severe depressions, but then you have periods where people are okay, they're euthymic, they have another depression, or they may have a mania, But the truth is, I mean, this is a current version of the truth, okay? Stanley Foundation is affiliated with the NIMH, and they're devoted to studying and researching bipolar disorder. Take a look at this prospective study. 2/3 of people have symptoms all of the time. And this is when, even when people are really having their major episodes of mania and depression controlled, they are not completely well in between. Okay? Chronic fluctuating symptoms and inter-episode chronic low-grade mixed states, what they now calling dysphoric hypomania. And if you'd asked me a year ago, what is dysphoric hypomania, for heaven's sakes, I would say, I don't know. But here's what it is. And it's like people start talking about this, and I go, oh yeah, I've seen that. Okay, with bipolar patients between episodes, they're not floridly manic, they're not terribly depressed, but they're revved. They're kind of revved up. They're kind of impatient. They may have a little bit of positive energy, but you just scratch the surface a little bit and you get a little irritability that comes through. It's like they're in this. That's what dysphoric hypomania is. Okay, and even if they're a little upbeat, boy, you kind of push them the wrong way a little bit, and they'll kind of snap at you. There's underlying irritability. Okay, so it's not true that they come back to complete normal, unfortunately. Episodic condition that often ultimately deteriorates into chronic treatment-resistant depression. And I wish I could go back 30 years and see some of these patients I've seen before knowing this, because one of the most important things I want you to walk away with here with bipolar is many people that end up being these treatment-resistant people have bipolar 2, and the hypomanias are few and far between, or they haven't had them for years. And they keep going to therapists and do psychotherapy and get antidepressants. Now, we said before, the antidepressants can cause a flip into mania, but if you have bipolar 2, you don't have mania. You may have 1 day or 2 days of a little bit of hypomania. But you know what happens most of the time if you have bipolar 2 and take antidepressants? Most of the time, just doesn't work. Okay? It may cause some hypomanias. That's not a big deal. I mean, hey, take a 3-day vacation, enjoy the relief. But also it causes something called cycle acceleration, which means they're going to be getting increasingly sicker. They're going to have more frequent depressions that last longer and are more severe. So there's a chunk of people out there that really are the so-called treatment-resistant depressed people that probably, not all of them, okay, but a number of them may have gone for years undiagnosed as bipolar 2. This is one of the reasons treating bipolar is very, very difficult. 95% have comorbidity. It's very significant, okay? Now, it depends on what study you look at, but at least half of them have significant comorbid anxiety disorders. And I'm not talking about they just have anxiety, but we're talking about full-blown disorders like OCD. Rates of OCD are high among bipolar patients, panic disorder, severe social anxiety, and that kind of stuff. At least half of them. And look at the substance abuse. This has the highest rates of substance abuse among any psychiatric disorder. Now, if somebody walks up to you and says, excuse me, can you tell me something? If you have bipolar patients and they're taking their medications religiously, I mean they're really staying with the medications, what are the 2 factors that are going to predict they're still not going to have a good outcome? And that is untreated anxiety disorder and untreated substance abuse disorder. And a lot of this goes underground because people don't talk about it. They lie. It's not they're not lying. They're ashamed. Okay, and they're not completely forthcoming about that. All right. And the problem here is if you just want to look at this from a medical model, the drugs that work best for treating anxiety disorders are antidepressants that make bipolar worse. Okay? Binge eating disorder. Rates of obesity are significantly more likely to occur in bipolar disorder than they are in the general population. This was noted long before there were any bipolar medicines. Back in the 30s, 40s, and 50s, they had about 3 times the rate of obesity. Okay? And then come along the bipolar drugs. 2/3 of them cause weight gain. And you also have, in addition to this, eating disorders, mainly binge eating disorder. Now here's an interesting bit of trivia, okay? And that is, in the United States, there are actually more men that are binge eaters, but there are more women that have binge eating disorder. Now, so what does that mean? To have binge eating disorder, you have to have binge eating and it bothers you. Yes?
Okay, I have a question. So, over half of people with bipolar have anxiety disorder, but you can't use antidepressants, which are the best, most effective treatment, but you also probably don't want to use benzodiazepines with a lot of your clients because there's a huge rate of substance abuse. So how do you treat it?
Psychotherapy and exercise. Perfect question. And you know what? A lot of people, I don't want to make too much of an overgeneralized comment, but a lot of psychiatry has become very medicalized, and looking at through the lens of what drugs do we use. And really and truly, if you look at outcomes in anxiety disorders across the board, OCD, panic disorder, social anxiety, the psychotherapies always are superior to the drugs, even in people that have just straight out anxiety disorders. Okay? Yeah?
I think you mentioned in another class that sometimes blood pressure medications are prescribed for anxiety.
Well,
Clonidine.
on occasion. Yeah, on occasion. Clonidine, it has been used. We'll see next, in another class, PTSD. Sometimes beta blockers, but usually those drugs are not used for very long because beta blockers and clonidine over the long haul can actually cause depression. So for very short-term use, that's certainly a possibility. Now, there's a drug, Neurontin, is used often to treat anxiety in people that have bipolar disorder. We'll talk more about that in our next class. So that's one drug. It treats all kinds of anxiety disorders except OCD. Okay, but I think we have to acknowledge that psychotherapy has got to be a part of this for most people, not just the drugs. Frequently misdiagnosed. This survey was done 10 years ago, but I think more recent studies have just shown the same thing. 69% of people were initially misdiagnosed as having unipolar depression. And guess what? If they got diagnosed, what did they get? They got antidepressants. Right? Look at this. This is a more recent finding. Frequently, only 20% of people get a correct diagnosis within the first year. And why does this matter? Well, it matters because they get antidepressants. Now, a part of the misdiagnosis has to do with this. Okay, if you have childhood onset bipolar, 70% of these kids, their first 1 or 2 episodes are depression before there is any hint of mania. And if you look at adolescents and adults, 60% of first episodes are depression. And usually they'll have 1 or 2 before there's any hint of mania or hypomania. So this is going to make it really important to look far beyond the notion of, is there a history of manic symptoms? Right?